Morning. Today I am presenting on behalf of Medicine 2. So she's a 40 years old female presented with complaints of dry cough for past 2 months and progressive dyspnea for the past 2 months. There was no history of loss of weight or loss of appetite. There is no previous history of fever. There's no hemoptysis or seasonal exacerbations. No other comorbidities, no other significant family history. So on examination, her respiratory rate is 22 per minute, saturation is 99% room air, pulse rate is 80 per minute. When she came, her blood pressure was 70/50, and the peripheries are warm peripheries. Systemic examination wise, respiratory system inspection is right lung field as a decreased movement is observed, and palpitation, vocal fremitus is increased over the right infrascapular, infraaxillary, interscapular areas, and percussion dullness is noted. On auscultation, bronchial breath sounds heard over the infraaxillary, infrascapular regions. Left side is normal, respiratory system is normal. CVS examination is as soon as normal, no added sounds. Per abdomen sinus also is normal, there is no significant findings. So based on the history, the differentials we considered were with a cough for 2 months with the exertional dyspnea, pulmonary tuberculosis, chronic heart failure, interstitial lung disease.
You're very, very localizing assessment at the end of your history and examination. You can't say anything and everything. You sort of have to rank order and say which of this would actually fit, isn't it? That's the way you need to think. Now, what are the things that are not fitting very well?
Chronic heart failure is like
okay. So why do you think chronic heart failure is not fitting?
Morbidal edema JVP is not elevated.
Okay.
One of the least possibilities.
Okay, so shall we move that out? Okay, we'll go through the other one.
Pulmonary tuberculosis is high likely.
Okay, so why do you think it's likely?
So cough more than 2 weeks and dyspnea, exertional dyspnea in ward when she had a fever spike. Even though the previous history was there.
So you feel some chronic infection is possible. Okay, keep that. Just go to the third one. Do you think ILD is possible?
There is no autoimmune disorders per se the previous records. But with this long history, we also considered a possibility of it, a 2 months history.
Tell me some ILDs that would choose to go to the right side of the lung and spare the left side. Sorry.
Not sure.
Are you feeling that the left side is also involved and you're not able to pick it up or something?
It was, let's say it was mildly there, like later we came to know, but initially it was not much of a.
No, you could make mistakes here. So maybe ILD, if you evaluate all these things, you're going to do a ton of investigations, isn't it? Which would sort of break the whole process of going through meticulous thought process. So you feel ILD is very likely?
Oh, less likely.
Okay, we'll move it.
And I have to show them my it's like a patch which is involved. So based on this imaging, so we started workup for the differentials we considered. The first differential was a TB we considered, this is a dry cough, so we did a GJ aspirin, which was negative. Her CRP was 181, suggestive of an inflammatory process. The ANA was negative, and the ACE for the sarcoidosis was 34, which is also negative. So we go ahead with the imaging, CECT thorax, which showed large confluence soft tissue density lesion in the right hilar region with infrahilar extension, and the features are suggestive of a primary lung malignancy.
That's a bit much, but you tell us why you feel that is so.
Because this hilar extension involving the middle and lower lobe, as I said, is a one-sided mass, like one-side involvement. So it's more of a suggestive of a primary malignancy is what the picture is. But there, even though she doesn't have a fever history before, in what she had a fever history and she came in a BP of 70-50. So a coexisting infective etiology also we considered. CT report came more like a malignancy. So, yeah. So we also considered a malignancy as the diagnosis, and we went ahead with the CT guided biopsy. But the CT guided biopsy report came out of the blue. So
maybe you just stay there. Say that this is a large lesion which is sort of encasing around the bronchus, and there are some satellite lesions also around, isn't it? So now you want us to think about chronic pathologies that might behave like a malignancy.
That may behave like a malignancy.
You want to choose people you want to ask that. Just choose whoever you want to ask.
Joseph.
I don't know who's Joseph. Who's Joseph? You're Joseph. Go on. What do you think? Something indolent going on sometime. Okay, so you want to consider IgG for disease. Okay, they can mimic the malignancy. Anything else? Okay, usually they're very sort of distributed all around, isn't it? I mean, okay. I'm biased towards infections. Can you think of any infections that can go for some time like that? The picture is not very clear, not very fitting. You could have some infections. Can you think of any? Okay, nocardia, just the host is a bit unusual, and things like aspergillus, or you could have actino, things like that doing this, isn't it? Slowly growing over some time. Okay. Anything else you had in mind which he has not touched? You want to discuss this? What are the other things? Oh, you're coming to that. Oh, please go ahead.
So conditions which mimics like a malignancy, as Sat told, the aspergillosis, granulomatous inflammation of the tuberculosis, which you already ruled out, could be a lymphoma, histoplasmosis, and lung abscesses, pulmonary amyloidosis, or pneumocystoma or sclerosing hemangioma. The one other thing is there in the list, which was our diagnosis, which it, so the one more the list is which is meniscus granulomatosis with polyangiitis. So there are a few case reports where a case of granulomatosis polyangiitis was mimicking like a lung malignancy. So there are 2-3 case reports where it is presented before. So our patient, because of this diagnosis, we sent a anti-PR3, which came as positive 128, and the CT guided biopsy showed a features of granulomatous inflammation consistent with the diagnosis of granulomatosis with polyangiitis. So making the diagnosis of GPA, the limited GPA only involving the lung involvement. So for our patient initially, because the patient came in a BP of 70-50, was requiring inotropic support, and because the suspected coexisting infection and treated with antibiotics with 7 days meropenem, the fever settles. Once she was settled, after that she was started on steroid pulse and cyclophosphamide, and after that she improved her CRP. Repeat CRP was 35. She was started on 1 mg per kg of steroids, and she was planned for further cycles of cyclophosphamide.
What in this biopsy makes you think of vaginous as a possibility?
Granulomatous.
So many granulomatous problems.
Small vessel vasculitis kind of picture. After that, history-wise, going on forward, she started developing, like, while now she's admitted this time for the pulse, that she has started having a nasal bleed, nasal crusting and spontaneous nasal bleed on an episode. Now she's having a left side hearing loss, sensory neural hearing loss, and the right side is also starting to develop, all in going in favor of a granulomatous polyangiitis. So still of renal involvement is not there, but the other pictures, as said, like those cutaneous pictures are all starting to more show now. So the learning points is a malignancy mimics. Regional granulomatosis mimics as a malignancy is a limited granulomatous polyangiitis. Thank you.
Any questions?
Yeah, it's quantified now. 24 urine protein is 166. And 24 urine protein was 166, which was insignificant.
Can you show how you manage this question?